Up next, Guenter Breithardt and Dr. John Teerlink, professor of medicine at the University of California in San Francisco and director of the heart failure program at the VA in San Francisco, discuss the relaxin in acute heart failure, or RELAX-AHF trial.
Dr. Teerlink, could you please tell me, how did you get interested in relaxin? It's not a protein which we as cardiologists are used to.
No, that's an excellent question. Well, as you know, the acute heart failure is just one of these huge problems that we have been trying to confront. And what we decided to do was have a lesson from Mother Nature in this regard. Because as you know, pregnancy is a physiologic state that requires massive adaptations to the increased stresses of developing fetus, including improvements in cardiac, vascular, and renal performance. And we also know that relaxin has anti-ischemic, anti-inflammatory, and anti-fibrotic properties, all of which are things that we'd like to have happen in acute heart failure. And given that both men and women have circulating levels of relaxin, have active signaling systems for relaxin, we felt it was an opportunity to investigate it in acute heart failure.
As I remember, there has been a previous study with a similar acronym. What was the result of this study? Could you shortly refer to that?
Exactly. Well, we did perform the pre-RELAX-AHF trial, which was a 234-patient pilot dose-finding study, where we saw that the 30 microgram per kilogram dose improved dyspnea, improved inpatient outcomes, and actually had signal for an improvement in mortality. We also were pleased to see that it was safe, well-tolerated, with no real hypotensive effects.
So, and that made you do the second study, obviously, and looking at your smile, you obviously had positive results.
Yes, obviously you'd like to play poker with me. Yes, we went ahead and performed the RELAX-AHF trial, which enrolled 1,161 patients, randomized either to a 48-hour infusion of serelaxin at 30 micrograms per kilogram per day or placebo.
So that was only short-term therapy during the early stage of heart failure.
Yes, and the patients that were enrolled in the trial were patients who were admitted for acute heart failure, had dyspnea at rest, had objective signs of congestion, mild to moderate renal dysfunction, and normal to elevated systolic blood pressure. In addition, we enrolled them within 16 hours of coming to the hospital. So these were patients we captured very early in their clinical course.
And of course, they all got standard medication.
Yes, they had standard care, and 7% of the patients were on baseline nitroglycerin therapy.
Do you have any data about the etiology of their heart failure problem? Coronary patients or a dilative cardiomyopathy? Or was it a mixed population?
It was definitely a mixed population. What we did have is we had the mean ejection fraction in the patient population was 39%, with approximately 55% of patients having less than a 40% ejection fraction. There was a healthy representation of both preserved ejection fraction and reduced ejection fraction patients. And I should also mention that these patients were very representative of patients in the community with heart failure, with acute heart failure. So they were, in general, elderly with elevated blood pressure, history of symptomatic heart failure, as well as elevations in troponins as they presented. So these were acutely ill patients. The only difference that we saw in baseline indications was an increase in the heart failure hospitalization rate, the prior heart failure hospitalization rate in the serelaxin-treated patients.
Which is a bad prognostic sign if you have had a previous heart failure.
It certainly makes you more likely to have later heart failure hospitalizations, yes.
In which countries did you do the study? Was it only in US or?
Oh, no, it was done in 11 countries, 95 sites throughout 11 countries throughout the US, Europe, and South America.
Well, and what were the results?
The trial evaluated two primary dyspnea endpoints, and it required that one of those dyspnea endpoints be hit at a value of less than 0.025. And we were fortunate to see that there was a 19% improvement in the visual analog scale area under the curve assessment of dyspnea through 6 days. And this had a p-value of 0.0075, so clearly demonstrating that we had met the criterion for showing improvement in dyspnea in this trial. So that was very important to us to see. The second primary endpoint, which was dyspnea relief by a Likert scale, looking at a much shorter time period through 24 hours, was not significant between the two groups.
But I think for the patient it's more important what's happening on the long-term run. So if you have positive outcome induced by the medication, what about long-term outcome beyond, let's say, hospitalization?
Sure. So the secondary endpoints were geared towards rehospitalizations. And the first secondary endpoint was the cardiovascular death or heart failure or renal failure rehospitalization within 60 days. And that endpoint was not statistically significant between the two groups. And interestingly, there were competing risks here because there was a trend towards improved survival in the serelaxin treated group in terms of cardiovascular death. And then there was a slight increase in the rehospitalizations in the serelaxin patients. So those offset, making this a non-significant endpoint. And as you might expect, the second secondary endpoint, which was days alive out of hospital through 60 days, which is also greatly influenced by the rehospitalization rate, although there was a advantage of plus 0.6 days for serelaxin, it was not statistically significant.
What about the co-medications? Were they the same in both groups, or could patients in the relaxing group receive less co-medications like diuretics or so?
During the hospitalization period, there was a 25% reduction in the use of intravenous diuretics, as well as a 25% reduction in the use of intravenous vasoactive therapies. So we had the improvement in dyspnea despite less other therapy. In addition to that, we had markedly less early and less persistent worsening of heart failure in the serelaxin-treated patients. So we were able to prevent some fairly significant clinical symptoms and signs in these patients. And all of this was then also accompanied by a decrease in the duration of intensive care unit stay, as well as a decrease in the length of stay. These culminated in a 37% reduction in 180-day mortality in this trial, with a p-value of 0.028, with a number needed to treat of 29 patients to save one death from cardiovascular causes.
But I think these are very impressive results. What about the mode of death? It's always difficult to separate between sudden death, arrhythmic death, and heart failure death. Do you have any data on that?
No, once again, that's an excellent question. As you know, we are just now presenting this as a late-breaking clinical trial. However, we had a superb clinical events committee that was run by Professor Michael Felker, and they will be working on that. And I should mention that we had a tremendous committee. Professor Marco Metra was my co-principal investigator in this trial and, shares both the blame and the success.
What about side effects?
We had carefully planned this trial to enroll patients with normal to elevated blood pressure to try to avoid hypotensive events. And so importantly, hypotensive-related adverse events were similar between placebo and the serelaxin-treated patients. In addition, there was no difference in the overall adverse event rate between the two groups and no difference in the serious adverse event rate between the two groups. There was an interesting difference, which was that in the serelaxin-treated patients, there were actually fewer episodes of renal impairment-related adverse events.
So I think these are really encouraging data, especially for my understanding that acute treatment or during a defined period translates into long-term improvement in outcome.
Well, it's interesting to bring that up because one of the things, if you look at the Optime HF data, which was with milrinone, you see those curves and there was clearly an early harm. But those curves actually kept spreading out over time, even though they only gave milrinone for a short period of time. And so we accepted that the curves could continue to separate when you did harm. And I guess now we just need to try to change our mindset to a positive one and say, well, if we can prevent harm early on, then the curves may continue to separate, but in the different direction.
Okay, I think this data may change our approaches to management of acute heart failure and one day may even enter the guidelines. And I think it's really reassuring that we see positive data coming out after having seen quite some studies in the cardiovascular field which were neutral, and it's so difficult to get positive results on the basis of the underlying standard treatment. And so I think your data are very encouraging, and I can only congratulate you. Thank you very much for joining us here.
Thank you. Appreciate it.